Hello, thank you for coming. This is Ruth Myers here, wanted to talk about traumatic brain injury, which is, as you know, a hard bonk on the head. Although there's other conditions that are similar, traumatic brain injury is specifically defined as a hard knock on the head. One of the things about traumatic brain injury is what they teach you when you're a young medical person is the opposite of what you know after you've met a bunch of people with traumatic brain injury. I have a number of stories I'll be sharing today. One, you have just heard if you just listened to the advanced directives presentation, because there is such an important connection between the two fields. A lot of what's taught about the future and fate of people with a severe head injury is often used to justify limiting or abbreviating care to people with traumatic brain injury, when in fact, the reality doesn't really support that whole approach at all. For example, there's this one gal. This is not her. This is an internet picture of her. She's 27 years old, woman referred to see me in one of my old practice a number of years ago for a little depression. She's got a little intellectual disability. She's got a little depression, already mentioned. She is a single mother. She's got a job. She doesn't like her job very much. Kind of not an uncommon presentation for a person who comes into a psychiatrist's office. Does that sound like a walk into a bar joke? I walked into my psychiatrist. Okay, never mind. Anyways, this is not her, the woman who came to see me. This is an almost identical picture from the internet that's allowed to be public. And as I was talking with her, the woman in my office, I noticed she had a dent right here. Only the woman in my office had a dent right there, but it was same kind of dent. Just like a divot on her forehead between her eyes. And I said, well, what's that from? When she was pregnant with her 6-year-old, she was shot in the head from a few inches away. She was resuscitated and given fantastic care, every kind of nurturing and therapy and nutrition and everything you could imagine, because they wanted to save the baby. Every single progress note said, well, she is in fact already deceased, but we're nurturing her body so we can hopefully save this baby. And she woke up and she's living her life. And still the people that worked with her, who wrote those terrible things, she's already dead, couldn't see in front of their eyes that what they'd been taught really didn't fit. And that's the story of people with severe head injuries. The amount of recovery can range from minimal to stupendous. And a lot depends on factors other than what's listed in the medical neurology textbooks. Traumatic brain injury results, like we said, a bad knock on the head or a bad jolt of the head. It can also result when an object goes through the skull into the brain tissue. The aqueduct of Smith & Wesson, for example, or something of that nature. Mild injuries affect brain cells temporarily, and brain cells heal slowly. They heal, but they heal slowly. Severe injuries can compound the injury to the brain cells with bleeding, bruising, and torn tissue. These complications can cause more and more complications and can result in death. And for people with traumatic brain injuries who don't survive, it's typically the complications that shorten their lives. What are Other conditions that are often receiving some of the same treatment, the same understandings, people with aneurysms in their brains, ruptured or unruptured, strokes, infections or inflammation of the brain tissue itself, abscesses in the brain, or hydrocephalus, where the fluid-filled spaces can't drain and they swell up and block and put pressure on the brain tissue so it can't work properly. Let's for a moment summarize all of neurophysiology. It'll only take a second. We got structural, we got electrical, we got chemical, and we got fuel line. And a disruption in any one of these can alter a person's brain function. So for those of you that are already restless and need to leave really, really, really early, the best source of information about a person with a brain injury is that individual person with the brain injury. The next best source is neurosurgeons and neurorehabilitation experts who have a good track record of recovery, which is different than saying somebody who's well trained or somebody who has lots of credentials. The only one that matters to me is how do their patients do. And the worst source of information is textbooks that try to issue prognosis based on seriousness of injury or the difficulty involved in the recovery. They have nothing to do with the given individual. Let's talk about a famous actor. In 1974, he fell while he was rehearsing a play. He had a severe head injury. He was unconscious for a very, very long time and comatose. He permanently lost his sense of smell and feeling in one elbow. But he wanted to return to acting right away, which is the thing he loved most in life. So what do you think? Should we let him? Who should decide what he should return to and when? Oh, you're thinking that maybe getting to do something he absolutely loves will accelerate his recovery? Well, I think you're right about that, and he's gone on to do pretty well. Bill Pullman, who's had a stupendous career and continues to do brilliant work now into his 60s. What was the thing that caused him to overcome his prognosis in a time when very little was known about how brains heal? Right? Doing something he loves. And that is another name for that. There's all kinds of names for it, but one name for that is neurological splinting, where one part of the brain that operates well and fills your whole body with pleasure washes you with those kinds of chemicals that help you heal all the other parts that are having a hard time. That's why rehabilitation centers that do really great work tend to be fun places. You go there and you just feel good the minute you walk in the door. They're the ones that do well. Or another person, you heard about him if you were attending the hospice presentation. 1946, a 9-year-old boy thrown off his bicycle, thrown headfirst into a tree. Got no treatment. Unconscious for who knows how long, and lost an entire year, has no memory until from ages 9 to about 11. Textbooks say, don't give this kid any resources. He's never gonna succeed. Why should we bother encouraging him? We should just tell him, be realistic. We'll find you a good job, sorting widgets somewhere. Who should we be consulting about what he wants to do and how hard he wants to work to do it? Who could that be? Oh yeah, him. So this guy went on to graduate high school with honors, went to an Ivy League school. He's also poor, by the way. He went to an Ivy League college on a full scholarship, academic, went to medical school on a full scholarship, academic, and practiced medicine. He also happens to be my father, so I know of him as being the best physician I've ever met in my entire life. So he's one of the many reasons that I have firm opinions about the whole idea of prognosticating without incorporating the given individual into the discussion. Motorcycle accident. The guy's 44 years old, not wearing a helmet. His skull was crushed and his brain was exposed. Torn off scalp, torn off skull after he flew over the handlebars. He was in neurosurgery just trying to save his life for 2 hours. He died several times and was resuscitated. He was in a coma for 4 weeks. A lot of conversations with the family. Why don't we just withdraw care? This has been such a hard road, and he might be tired of fighting. But thankfully, people who know him said, well, he's still fighting, so are we. And he walked out of the hospital 5 weeks later. It's Gary Busey. And he's in fact returned to acting. He's a little different than he was, but he's still pretty darn talented and functional, isn't he? What contributed to the accident? What contributed to the recovery? Right? Accident was related to a variety of lifestyle issues, and recovery was related to pretty strong urge to fight, no matter what, for him. He got great care. He insisted on it. His family insisted on it. (1986), age 33, athlete, really amazing athlete. He was engaged in his preferred sport and sustained a depressed skull fracture with hemorrhage, which means bashed in a big dent in his brain. He was not supposed to live. He had emergency neurosurgery. It saved his life. He's 33 years old when this happens. He was in a coma for 7 days, and his family was pulled together to say goodbye. Now he wants to go back to engaging in the same sport. What do you guys think about that? One school of thought, are you nuts? Look what happened to you. Other school of thought is, whose life is it? Well, he went on and did okay. Jackie Chan, who's still acting, and he's pushing 70. Did all right, didn't he? What was it? What was it? This is one of the essential points for effective support of people who've had brain injuries, is that a big hunk of their everyday life has to do with stuff they love. People they love, media they love. Doesn't have to make sense, but it's got to be there for that person to really get their best level of recovery. You may have heard a little bit about this guy. He's 10 years old. He's kicked in the back of the head by a farm animal. Bad. He was unconscious for a long time, more than a day. Got no treatment. And he had permanent damage to his vision. And it was because the injury was to the back of his head, which is where all the things are that we use to process visual input. But he wants to be a lawyer. Comes from a really poor family, lives in the woods, wants to be a lawyer. With a head injury like that, what's the likelihood of him even learning to read and write? Well, according to the books, there's no possibility. But people decided to encourage him and support him anyway. And he did all right for himself and all the rest of us. Again, his passion. What was it he really wanted to do with his life? It's one of the reasons why I object so much when people are trying to teach people with different kinds of neurological issues, and they use cartoons or pictures or stories or topics the person doesn't care about. That's just boredom. But if I have known a number of people where when the teaching tool incorporated something that person loves, whether it's Marvel characters or the presidents of the United States or the periodic table or whatever it is, the pleasure involved with that intellectual stimulation will help the learning accelerate. So we've got this exceptionally skilled, intelligent athlete. Very, very skilled. Graduated with honors from college before he went on to become a professional football player. He retired from the sport. His personality changed. He was arrested for domestic violence, and he died by suicide at the age of 43. He shot himself in the heart because he wanted people to study his brain, Junior Seau. And he helped so many people by getting the professional football world to take a much closer look on an entity called chronic traumatic encephalopathy. And this is the people that we know, people that bang their own heads, people that are subjected to a lot of abuse, people that play sports without proper head protection, people that keep re-injuring the brain and not giving it enough time to heal. Gradually increasing degeneration of the brain tissue caused by repeated blows to the head without enough time to heal between injuries. And when all this stuff came out about Junior Seau and some of the other professional athletes, it turned a lot of us off from professional football, didn't it? But then they put in all the protective measures, and I say, all right, you're trying to do it right. That's very good. So I think there's been progress. Boxers, athletes, military veterans, depression, cognitive problems, paranoia, memory loss, impulsive behavior are the outcomes from chronic traumatic encephalopathy. Now, what is the fix for a person who has it? The first step is recognition. For a long time, people just kind of, oh, they probably are just drinking too much. Oh, they probably, dismissive. But in fact, a comprehensive program of nutrition for the brain and rehab and proper treatment of the complications can really help people make an enormous amount of progress and not be so miserable as they can be from this traumatic encephalopathy. Recognizing what it is and dealing with it is the first step, right? Instead of just dismissing it. In 1848, a 25-year-old man was working with a metal rod and explosives. Not a perfect combination, I'm thinking. The rod was 1.25 inches in diameter, 43 inches long, made of steel. The powder that he was working on, the explosive powder, exploded and drove the rod up through his cheek and through both frontal lobes of his brain. He walked to a cart and spoke after this accident, after the rod flew through his brain. He developed an infection, and that's what put him in a coma. He was in a coma for 10 days. And a month later, he was well enough to leave the house that he was recovering in. You know, and a lot of people talk about all the problems with Phineas Gage. He's the guy where the rod went through his head. In fact, he would go from place to place, and what he's holding in his hand is the rod that went through his head and through the anterior parts of his brain. His personality was really changed. There was a lot made about that. This is, frontal lobe injury. This is what happens. Lost his skill with numbers. He was unmotivated and disinhibited at the same time. And he was kind of a grouch. But, and this is an important but, it's pertinent to everything to do with brain injury. He got better. After people wrote and wrote and wrote about what all these injuries did to him personality-wise, they didn't watch him long enough. 2 years after this accident, he was able to work in a livery, then worked as a stagecoach driver for 7 years. At least as complicated as anything he'd ever done beforehand. And the cause of death was not the injury, the cause of death was seizures. And this is the story, isn't it, of people with traumatic brain injuries, is that the injury heals. The complications are what may take a person out. So what are those complications? Not necessarily permanent, because brain cells do change, they do heal. Personality changes. Patchy cognitive changes. The person can still do calculus, but long division is gone, for example. Headaches, sensitivity to light, seizures, oversensitivity to medicines that affect brain function, and tons of medical discrimination. It's often one of the reasons I hesitate to document it when I'm writing a report. I always do because it's important. But in certain parts of the medical system, once they hear TBI, they automatically make a whole lot of assumptions that lead to less care than anybody else would get. So if a person has a head injury, what should emergency care look like? What should we be advocating for? There's a concept called the golden hour, which is right at the beginning. As soon as we see a change, an immediate evaluation by a center of excellence improves prognosis, which means I will call for the air ambulance. I did that for a while. Back in my youth, I was one of the ones that was in the helicopter and stuff. That was sort of cool. I learned a lot. Not sure I contributed much, but I learned a lot. But people will say, airlift, really? Yes. If airlift is what you need to get the person to a center of excellence within the hour, that's what we should be pushing for. Will we get it? I don't know, but that is the correct thing to push for. If neurosurgery is needed, sooner is better than later. And sometimes a therapeutic coma is the best way to prevent injury from spreading related to the traumatic impact or the bullet or whatever it is that's producing the injury. So the golden hour, if we can get things organized fast enough, person falls on their head, they're knocked out, golden hour. If we can, we always try, right? We try and do what we can do. Longer term brain injury care involves brain rest, which is a lot harder than it sounds. Holy buckets. Monitoring for complications. What are those? Hydrocephalus, infection, seizures, right? Treatment of co-occurring issues. When I've seen people with brain injuries not do well, it's because people forget about all that other stuff that's attached to the brain, like the urinary tract or the lungs or the stomach ulcer or like that. Elimination of brain toxic chemicals, which is hard because so many of them are kind of regular everyday medications. When we talk about medicines, we'll talk about some of these medicines that can exert some severe problems for people that have intellectual disabilities, or particularly for people who have brain injuries. Examples would be medicines like H2 blockers, like Tagamet, Zantac, or Pepcid or Axid, or beta blockers, which are used for a lot of heart stuff. Atenolol, propranolol, metoprolol. Those are very toxic to a person's ability to think and concentrate. Alpha blockers, medicines like clonidine and so on, as well as some of the psychotropic medications, are a lot more stupefying than others. And general health and wellness. And I put that as a little phrase, but that's a huge, huge investment, isn't it? People needing to make that investment in the proper kind of nutrition and making right in their relationships and sleeping the right number of hours and all those things that are hard for any of us in this day and age. This is the Glasgow Coma Scale, and it's just a number that's a way to measure people's alertness and awareness and emergence. The sad thing about it is that people keep trying to use it to predict things, but when the research is done properly, it doesn't predict anything. It just tells you where you are in a point in time. The correct use is point in time. And this is National Library of Medicine. However, although it is one of the most powerful clinical prognostic features, neither the Glasgow Coma Score nor any single feature alone should be used to predict an individual patient's outcome. So more and more people are proclaiming this in the more mainstream neurological literature. Coma-related errors, failure to wait for all the sedatives to clear a person's system. If a person's had emergency surgery and they went under anesthesia and they're slow to wake, could be because they're slow to wake. Some people don't wake from anesthesia for days, just the anesthesia they had days ago, for example. Or any other kind of sedating medication, antihistamines, sleeping pills, panic pills. All those have markedly exaggerated effects when you're sick and comatose. Incomplete assessment of sedation due to non-brain injury factors. And that can include infection, meds, low blood pressure, blood sugar problems, either high or low, viscosity syndromes, PTSD, catatonia, endocrine factors, and so on. Malnutrition is a terrible problem in many emergency intensive care unit settings. People often just forget that the person needs more nutrition, not less, if they're going to recover from this catastrophic injury. And lack of stimulation. So these are the things that we can watch out for when a person's being cared for by these very, very busy professionals, to say, hey, how about the parenteral nutrition? How about the coma physical therapy? How about massage? We can do that. We can arrange for that. All the things that can help a person heal and recover as well as possible. Coma-related errors in persons with IDD are forgetting if the person is deaf or blind and drawing conclusions based on their lack of response to auditory or visual stimuli. We've seen people do it, haven't we? DSPs or lead staff or DSP4s having to make a sign this big. Jane is deaf, failing to assess for non-convulsive status epilepticus. There's a type of seizures that occur much more often in people with IDD, where they're seizing, but they're not having convulsive movements, but their brain is in a continuous seizure. And not knowing the person's pre-existing alterations. The reason this person may not be able to raise their hand when ordered to is that they've never been able to raise that hand, not because they have a head injury. Coma treatment, like I said before, you don't need a miracle, you just need patience. The idea is to create the optimal environment to assist a person's brain to heal. Again, not as simple as it sounds, right? Correct intracranial pressure. Big thing when a brain is healing, if there's swelling, if there's fluid being retained, those things can put pressure on the brain and slow down the healing. Oxygenation of the brain and the rest of the body. Nutrition, stimulation, what do we talk about? Massage, PT, music, conversation, positioning, and some places use low doses of stimulant medicines to try and wake the person up. That's after they may have had a therapeutic coma. The cautions, these are cautions that we have to watch for and advocate against. Some clinicians still try to say that if you've been in a coma for X amount of time or Y type of injury means they can't recover. And that's just not true. It's not borne out by reality. Yet, people will try and say those things as a reason to stop providing care. Some have a magical belief that they can guess who will recover and who won't. The research shows that once they make a prediction that someone won't recover, they make sure the person doesn't recover. Excessive sedation, missing the opportunity to treat co-occurring conditions, and so on. And I think we've talked about that in other seminars. Many clinicians start with the idea that acquisition of a new disability is somehow this terrible tragedy and that nobody would be able to tolerate, when in fact most people, if that does happen, they tolerate it really well. And some clinicians still say that all the healing from a head injury occurs in the first 6 months. But in fact, in reality, the healing continues for years and years and years, barring setbacks. So what happens in neurorehabilitation? Find out what's been preserved and capitalize on those skills, like we were talking about before. Stuff the person loves, stuff the person's still good at. Treat the co-occurring conditions in a way that preserves remaining function. For example, if the person has high blood pressure, don't use beta blockers to treat it. Use some other medicine to treat the high blood pressure, because the beta blockers interfere with cognitive function in all kinds of different ways. Observe for new skills or new personality characteristics. Fill the days with as much pleasure as possible. Overall body health. Creation of new tracks for the neuromuscular junctions. And this is part of sensory motor psychotherapy, all kinds of body-based recovery plans where what we do all through here has an impact up here, doesn't it? Developing internal splints, developing external splints. Internal splints is if I think about a certain piece of music while I'm trying to concentrate, I do better. Or if I remind myself of something happy, that gives me the energy to push through this difficult task. External splints, people that tend to use a lot more paper and pencil, or they structure their schedule differently, or they, if reading visually is hard, they get people to be readers because auditory is easier, for example. That was actually my college roommate. She had a head injury, and just reading, wore her out really fast, but having somebody read to her was much easier. She was able to absorb the information. It was all head injury related. It was a great coping external splint. Different parts of the brain wake up at different times. And people that have a lot of experience working with people coming out of comas will often say that the really angry part of the brain might wake up first, And not to make too much of that. It's a process. Recovery can occur fast, slow, and both at the same time. Memory and recall is often unpredictable. Some nutritional supplements might help. The evidence is not great, but there's still some good evidence to consider. Spiritual support can be extremely helpful in all kinds of different ways. And obviously, like we talk about with everything else, the best support people are patient and optimistic. So what are everyday ways for us to help somebody we care about who's had a traumatic brain injury? Well, what and who does the person love? How can we get more of that in that person's life? Does the person have personal goals? It can be a heck of a motivator. I want to be recovered enough to attend my best friend's wedding. I want to be recovered enough too. What is the person still good at? And how can we keep celebrating that? What are the common complications? Let's watch out for those, because we as people that love the person and spend time with the person are going to notice that stuff faster than other people. Are there any other stresses in the person's life, anything we can take off their plate so that they can focus on recovery? What makes the person laugh? Because what do we say? Sorry, cliche time. Laughter is the best medicine. And what does this person find soothing? I know people make a lot of like aromatherapy and stuff like that, but I gotta tell you, lavender drives me up the wall. But for other people, it's magic. So sometimes we'll just have to try stuff, right? Let's talk about another person. In January 2006, he had a head injury. He was 46 years old from a bomb. He was in a war zone. The injury included bits of metal lodged in his brain. Part of his skull was removed. And the old trope or the old thinking was once the brain's been exposed to the air, the chance of recovery is, not measurable. It's negligible. Yet, I'm telling you so many stories where that's exactly what happened. He was unconscious for days. Then he was in a medically induced coma for 36 days. And then he couldn't speak for a year. What's his prognosis? Well, once he did start to speak, he said he wanted to go back to being a reporter. What do you think about that? I mean, that's going to be a lot of stress for him to try and go back to that old job, which almost killed him, right? Should we? Whose decision is it? Obviously, it's his. It's Bob Woodruff. He was back on the air in February of 2007. Fully recovered, fully functional. Not bad, huh? Paul was 28 years old. He'd been beaten unconscious many, many times. He has an intellectual disability. He was found chained in the backyard with the family dogs, starving. At the time when we meet him, at the age of 28, he has the physical development of a 5-year-old. He communicates without speech, and the service agency was told by the neurologist that nothing could be done. He would never mature. He would never be able to progress beyond the condition they found him in because the head injuries were so egregiously severe as well as the trauma. So what are the questions? What does he love? He actually loves dogs. God bless him. He's chained with the dogs for all those years. His personal goal is to fly airplanes. He shows you this with pictures. He doesn't have the words for it, but that's what he shows you. What's he good at? Busting stuff up. He loves to destroy property, other people's. And you can see the pleasure when he's doing it. So it's like people in his service agency brought stuff from all around just so he could bust it to pieces because they could see how much he enjoyed it. He had been starved, along with the severe head injuries. And what makes him laugh? The Three Stooges? Golly, that's horrible. But he loves it. And he loves to watch a single segment of The Wizard of Oz when the witch gets melted. He watches that 100 times a day if he can. The neurologist is pushing for hospice. He's got some seizures. He says, maybe we just take him off the seizure medicine and maybe he could go out that way. His interest in dogs and the Three Stooges was counterintuitive, and his conservator was arguing against him having access because of the obvious trauma trigger issues. The old-style behaviorist said the destructiveness was an inappropriate behavior, and we really need to come up with a program to get him to quit doing that. What do you guys think? He watches the Three Stooges and the Wizard of Oz segment every day. He got a part-time job walking dogs. He picked out and was supported to have the dog of his choice. Big, ugly, scarred-up pit bull. Favorite dog. Got a paying job at a recycling center, busting stuff up. Got treatment of migraines and depression and malnutrition. Fired the neurologist and the behaviorist. And 1 year later, he's 6 feet tall, weighs 180 pounds, can speak 3 and 4 word sentences, and is looking around for a girl. None of that stuff was rocket science, was it? But it was all based on all the principles we've talked about. The topic of brain injury often brings up the topic of advanced directives, which is a much longer seminar we'll have another time. I want to mention something about the issue of brain death. There is an accepted definition of brain death and accepted criteria. And what it means is there's no impulses coming from the brain, any part of the brain, including the brainstem. So if the person is still breathing, digesting, blinking, that means part of their brain is working. And when all that shuts down and all the reversible causes, right, the sedating medicines, the morphines, the Ativans, all of that have been eliminated, and all the infections and the seizures and the this and the that, then it might be possible to make the diagnosis of irreversible brain death. I think it's terribly important at all times that we as advocates always counsel careful, deliberate, take our time decision making, because people's lives are often depending on that. I just wanted to talk about a few more people. For example, Karen. Karen had an unwitnessed cardiac arrest found in a car by the side of the road, 46-ish age woman. As soon as she was found, resuscitation was started, but nobody knew how long she'd been down or how long there'd been no circulation to her brain. Vital signs were fully restored, but she did not wake up. She was admitted to the hospital, and just as they were trying to make a case to say, maybe we shouldn't do anything, her husband, a lawyer, showed up to keep her company. So they reevaluated the whole situation. She got stupendous care after that. Once again, back to that point of everybody should have an advocate when they're in that vulnerable of a position. And an advocate that can't be dissuaded, can't be talked out of the proper care for a person. This Karen was my practice administrator in my practice in Minnesota. She was the den mother for our entire group, and 5 weeks after this event, she came back to work full time. Kicked butt. She got proper care, but she wouldn't have if it hadn't been for advocacy. Michael had an unwitnessed cardiac arrest, but the resuscitation was started immediately. He lives in a supervised living situation. He was resuscitated within minutes, but he didn't wake up immediately. He was, after 4 hours in the hospital on high doses of sedating medications, his family was told there was no hope of recovery and he should be extubated. And they bought it, and he died. Why? For all the reasons we talked about. He happened to have severe to profound intellectual disability, so the people that were pushing this decision on as conservators were highly biased against valuing his life. So some more ideas about people with traumatic brain injuries and their recovery. Cognitive budgeting. This is a situation where, unlike working muscles, when you work the brain, you need to know when to quit. Because if you work it too hard, the person will be set back. Doesn't make people stronger. This is a very different kind of an operation than other kinds of physical fitness. How long can the person focus and concentrate? What is the highest personal priority? And people do better if they explicitly organize their days so that the highest priority, most important issues, the most meaningful issues, start the day, and then the rest of the day is rest and pleasure. The brain is different than the heart and other muscles like the heart. Pushing too hard does not make it stronger. Rest and pleasure accelerate healing and recovery. Memory budgeting, also important. How many pieces of information can a person keep in their head? Each piece that they try and keep in their head is bandwidth that may be extremely limited if they've had a head injury. So one of the ways people cope is to write every single thing down so their head is clear for the next piece of information. This helps other people too, but it turns out to be an absolute essential for people who've had certain types of severe head injuries. Does the person want something constantly available in their head? They may, but it's easier for them to do that if they also keep a backup, which sounds paradoxical but isn't. It's another one of those things where if you make it easier, it's more likely to happen, unlike the no pain, no gain idea that people have for other types of recovery. Patty, 53 years old, loves church, wants to go every single day. She had a very, very serious head injury when she was a teenager, and she had a BCBA who made it her personal crusade to get Patty to bathe, dress, and feed herself without any support. So you probably can guess what Patty's BCBA did and how it worked out. So the BCBA thought, since Patty loves church, let's leverage church by saying she can't go until she bathes, dresses, and feeds herself, according to our criteria. But if the issue is head injury, is that going to work? Of course not. It's the opposite of what is appropriate to do. To fill her life with the things that give her pleasure, make it much more likely for her to have any energy left over for things she believes are drudgery. And going back and forth on this was a long advocacy journey. But fortunately, the BCBA was honest enough to gather accurate data that showed absolutely that if Patty was supported to do what she loved, she was much more willing to do the stuff that wasn't that important, probably in her best interest. Some nutrition notes. These are some different kinds of foodstuffs that tend to be very helpful for people with traumatic brain injury. Caffeinated black coffee. And I just got my geek on with the neurologists at Harvard who are even pushing this harder than they used to. They used to say 1 or 2 cups. Now they're saying 3 cups a day of strong black coffee is good for people, particularly people who've had a head injury. Go figure. The pendulum will swing back and forth. Whole food, plant-based, organic foods are considered to be very helpful for people from a cognitive recovery standpoint. Lots of fluids, electrolyte balanced fluids, not free water. Well, free water is important for weather like we have in the summer in California, but also electrolyte balanced fluids are important. If it tastes good, that improves the benefit because it lights up more parts of the brain in a good and healing way. Carbohydrates are brain food. Very important. That's the only thing the brain can run on is glucose and byproducts of metabolized carbohydrates. Very, very important to avoid ketone diets or low carb or absent carbohydrate diets for people that are trying to recover from a brain injury. They need the carbohydrates for their brains to heal and recover and function. It's also nice, if we can, to reduce inflammation as much as possible. Simple sugars tend to irritate some people, not everybody, thankfully. Other kinds of inflammatory foods should be reconsidered, and for each person, trying an elimination. Some people find that it makes no difference at all if they cut simple sugars. Other people find it makes a big difference. It should be a highly individualized, but these are some guidelines to think about. Some supplements that integrative medicine physicians might or might not endorse. And these are they have some evidence to support their use in brain healing and recovery. Phosphatidylcholine and serine at a dose of 1,200 to 1,300 milligrams a day is a brain healing supplement. And people tell me, when I've suggested this is something other people advise, they try it, they like it. Alpha lipoic acid, well researched at the University of Minnesota for treatment of neuropathy, which translates therefore into healing of other types of nerves as well. Rather than suppression, it seems to facilitate, in fact, healing of those neuropathic injuries. B complex, carnitine, vitamin E, there's some controversy about this. And I think it's also terribly important to measure levels of vitamins once, at least, because you wouldn't recommend niacin for everybody, but if a person is deficient in niacin and they get pellagra, their recovery will be tremendously slowed. But if you treat that pellagra, their recovery will be accelerated. Supplements to avoid, unless the person has an absolutely confirmed deficiency state, are chromium, selenium, and copper. These are all neurotoxic, and if they build up, they will, again, impede the recovery of a vulnerable, injured brain, and most other people as well. Medications to avoid, like we talked about, beta blockers, alpha blockers, water pills, diuretics, H2 blockers, antipsychotic medications unless the person needs treatment of hallucinations. Benzodiazepines if possible, so that's lorazepam, clonazepam, Valium, and certain sleep medicines, Ambien and Halcion, are the worst offenders. And then we've got some controversial medicines. I have opinions, and of course I don't have any firmly held opinions about anything. I'm sure you could tell that. Kidding. There's a lot of controversy about the role of cannabis products in people with head injuries. Statins, which are used to lower cholesterol. There's some people that believe they also produce neurological injury. And Antipsychotic medications for people that don't have hallucinations, bupropion, which is Wellbutrin, and sleeping pills. A lot of controversy. Some people say that sleep deprivation, for example, is much more dangerous than the side effects of sleeping pills. So it's something to discuss, to think about. Medicines that seem to help accelerate recovery: antidepressants, low doses of anti-epileptic medications, seizure medicines, some low-dose stimulants, and some low-dose dopaminergics, medicines that treat Parkinson's disease, but at much lower doses. Other helpful modalities for recovery, if the person likes them: massage, yoga, dance, spiritual stuff, sex, lots of sex, laughter, and other sensory experiences, extremely individualized, whether it be a visual or an auditory or olfactory, gustatory, what have you. Good sleep is essential, really, really important. And drug-free, of course, we'd like that. Can't always get it, but it's nice if we can get it. Really important to avoid additional head trauma if possible, right? Activities that wrench the head and neck. Excessive alcohol use. The jury is still in deliberations about minimal alcohol use. One camp says there's no safe level of alcohol use for people who've had a head injury. Other people say minimal use, 2 drinks or less a week, is probably fine. It's all over the place. Stay tuned. Nasty food and odors are very triggering, and they really interrupt the recovery process for people with head injuries. Uncontrolled noises and a deeply peaceful, quiet environment, or an environment where the noise is entirely controlled by the individual, is preferable. And like we talked about before with the gal who likes to go to church, leveraging pleasure experiences is not helpful and is the wrong way around. So really important, if you can, to maintain a file of all the lab reports, the objective data, the imaging reports, the EEG reads, and so on. Find someone you can trust to look at those data. Say, are we on the right track here? And here's some other travelers that have good information to offer advice, to offer that second or third or 12th opinion. American Association on Health and Disability publishes an amazing journal. The International Association for the Scientific Study of Intellectual and Developmental Disabilities, is probably the best organization for overall information. DDNA, I love those guys. So other sources of input can really benefit the person. To summarize, people with traumatic brain injuries often experience a number of late complications. The science of helping brains heal is continuing to evolve. What's been carved in stone today may have no value down the road. The evidence in front of our eyes and in the published literature indicates that the prognosis is improving. Should not be surprised, right? The better and more whole person the care, the better people do. The most important elements are nurturing, patience, rest, pleasure, intrinsic motivation, and optimism. In severe traumatic brain injury, the question of ending the person's life is often raised inappropriately if the person has a developmental disability. And we need to guard against that. Just get people to take their time, not be in a big rush. Things take time. And recovery requires an individualized and creative approach to care and support. And, as they say, hey, can we do that? The things that a person might need or ask us to do, or the things the person may do themselves, may look at first blush to be a little funny, a little awkward, a little silly, but it's important to go with it. And that's how the person wins. Thank you for participating.